Question 1. A 35-year-old pianist presents with a several-month history of insidious onset of pain and paresthesias in the ulnar 2 digits and the ulnar aspect of the palm. The pain is worse at night and with sustained elbow flexion. Examination reveals a positive Tinel sign at the cubital tunnel and weakness in thumb adduction and intrinsic hand muscles. What is the most appropriate initial non-operative intervention? A. Nighttime splinting with the elbow in 45 degrees of flexion. B. Static progressive splinting to increase elbow extension. C. Custom molded thermoplastic elbow pad for daytime use. D. Activity modification to avoid prolonged elbow flexion and direct pressure. Answer: D. Activity modification to avoid prolonged elbow flexion and direct pressure. This question focuses on the initial management of cubital tunnel syndrome, which involves nerve compression at the elbow, indicated by ulnar digit paresthesias, nocturnal symptoms, and intrinsic weakness. The most crucial initial non-operative intervention is to address the causative factors by modifying activities that exacerbate symptoms, such as avoiding prolonged elbow flexion, like holding a phone to the ear, or leaning on the elbow. While splinting can be helpful, nocturnal splinting typically positions the elbow in slight flexion, 30 to 45 degrees, to prevent full flexion, not increase flexion, and a custom elbow pad is not the primary initial strategy for symptom reduction. For instance, advising a patient to avoid sleeping with their elbow fully bent under a pillow is a common and effective initial step. Remember that alleviating mechanical stress on the nerve is always the first line of defense in nerve compression syndromes. Question 2. A patient undergoes flexor digitorum profundus, FDP, zone 2 repair of the middle finger. According to a modified Duran protocol, what is the most appropriate postoperative management for the first 3 to 4 weeks? A. Immediate active range of motion of the middle finger. B. Immobilization of the middle finger in full extension using a dorsal blocking splint. C. Passive flexion of the PIP and dip joints within a dorsal blocking splint, followed by active extension to the splint's limits. D. Active isolated FDP tendon gliding exercises with wrist in neutral. Answer: C. Passive flexion of the PIP and dip joints within a dorsal blocking splint, followed by active extension to the splint's limits. This question tests your knowledge of early postoperative flexor tendon repair protocols, specifically the modified Duran protocol for Zone 2 repairs, which is a common and challenging area due to the no man's land of flexor tendons. The core of the modified Duran protocol involves controlled passive motion, where passive flexion of the PIP and dip joints occurs within the limits of a dorsal blocking splint, wrist in 20 to 30 degrees flexion, MCPs in 50 to 70 degrees flexion, followed by active extension to the splint's limits to promote tendon gliding without excessive force on the repair. Immediate active range of motion would risk rupture, and full immobilization would lead to adhesions, while isolated active FDP gliding exercises are introduced later. For example, a therapist might gently flex the patient's finger while the patient actively extends it back to the splint. The key is to balance protection of the repair with controlled movement to prevent adhesions and promote healing. Question 3. A 60-year-old female presents with progressive stiffness and pain primarily in the carpometacarpal, CMC, joint of her right thumb. Radiographs confirm severe osteoarthritis. She reports significant difficulty with pinch activities and opening jars. Which splint design would be most effective for long-term management of her symptoms? A. A custom-molded static volar wrist cock-up splint. B. A prefabricated soft neoprene wrist and thumb spica splint. C. A custom-molded rigid thermoplastic thumb CMC stabilization splint. D. A dynamic MCP extension splint. Answer: C. A custom-molded rigid thermoplastic thumb CMC stabilization splint. This question addresses the effective non-operative management of thumb carpometacarpal (CMC) osteoarthritis, a common condition causing pain and functional limitation, particularly with pinch. A custom-molded rigid thermoplastic thumb CMC stabilization splint is considered most effective because it precisely immobilizes and supports the arthritic CMC joint, reducing pain during activity and rest, while allowing full motion of the MCP and IP joints. Prefabricated soft splints may offer some compression but lack rigid support for severe arthritis, and a wrist cock-up or MCP extension splint does not adequately support the thumb CMC joint. For instance, the splint would position the thumb in slight palmar abduction and opposition, providing stability to the joint. Remember that stabilizing the painful joint while allowing maximal function of other digits is a hallmark of effective splinting for osteoarthritis. Question 4. A patient sustained a high median nerve laceration at the distal humerus 6 months ago. During your evaluation, you note profound weakness in forearm pronation, wrist flexion, and thumb opposition. Which of the following sensory tests would be most appropriate for assessing return of protective sensation in the median nerve distribution? A. 2-point discrimination. B. Semmes-Weinstein monofilament testing. C. Vibratory perception at 256 Hz. D. Sharp/dull discrimination. Answer: B. Semmes-Weinstein monofilament testing. This question tests your understanding of sensory assessment techniques, particularly for nerve injuries where the goal is to evaluate the return of protective sensation. Semmes-Weinstein monofilament testing is considered the gold standard for assessing thresholds of touch pressure sensation, which correlates directly with protective sensation. While 2-point discrimination assesses nerve density and discriminative sensibility, and vibratory perception and sharp/dull tests evaluate specific aspects of sensation, the monofilaments provide a quantifiable measure of light touch necessary for protecting the hand from injury. For example, a patient unable to perceive the 4.31 monofilament would be considered to have absent protective sensation. Always prioritize methods that directly assess the patient's ability to protect themselves from harm. Question 5. A 48-year-old carpenter presents with a sudden onset of pain over the dorsal radial aspect of his wrist following a prolonged period of using a new power tool. He describes pain with repetitive wrist flexion and extension, and a palpable crepitus is noted over the intersection of the first and second dorsal compartments. Which condition is most likely indicated? A. De Quervain's tenosynovitis. B. Intersection syndrome. C. Radial tunnel syndrome. D. Ganglion cyst. Answer: B. Intersection syndrome. This question requires distinguishing between several conditions affecting the radial side of the wrist, emphasizing key differentiating symptoms. Intersection syndrome is characterized by pain and often palpable crepitus over the dorsal radial aspect of the wrist, specifically at the intersection of the first dorsal compartment, APL/EPB, and the second dorsal compartment, ECRL/ECRB, tendons, typically exacerbated by repetitive wrist flexion and extension. While de Quervain's tenosynovitis also causes radial wrist pain, it is localized more proximally over the first dorsal compartment and primarily associated with thumb movements, lacking the characteristic crepitus. Radial tunnel syndrome involves nerve compression, not tendon inflammation, and a ganglion cyst is a soft tissue mass. For instance, imagine the tendons rubbing against each other like ropes on a pulley, causing friction and inflammation. Pay close attention to the exact location of pain and the presence of crepitus to differentiate these conditions. Question 6. A 28-year-old male sustained a displaced intra-articular distal radius fracture treated with open reduction internal fixation, ORIF, 2 weeks ago. He is currently immobilized in a removable sugar tong splint. The primary goal of therapy at this stage is to A. Begin passive wrist range of motion exercises to prevent stiffness. B. Initiate gentle active range of motion of the elbow, shoulder, and digits. C. Perform resistive gripping exercises to improve strength. D. Apply heat modalities to the wrist to reduce pain and increase extensibility. Answer: B. Initiate gentle active range of motion of the elbow, shoulder, and digits. This question tests your understanding of early postoperative management principles following an intra-articular distal radius fracture, where maintaining mobility of unaffected joints is critical. In the early postoperative phase, typically 0 to 6 weeks, the primary goal is to protect the fracture fixation while preventing secondary complications. Gentle active range of motion of the uninjured, adjacent joints, elbow, shoulder, and the digits, fingers and thumb, is crucial to prevent stiffness, edema, and disuse atrophy without stressing the healing fracture. Passive wrist range of motion, resistive exercises, and heat modalities to the fractured area are generally contraindicated in the very early stages due to the risk of disrupting fixation, increasing swelling, or promoting heterotopic ossification. For example, encourage the patient to perform shoulder shrugs or finger wiggles frequently throughout the day. Always prioritize preventing stiffness in uninvolved joints while rigorously protecting the surgical site. Question 7. A 55-year-old office worker reports chronic insidious pain in the lateral elbow, worsened by typing and lifting. She has tenderness over the extensor carpi radialis brevis origin. She has failed conservative management including rest, NSAIDs, and stretching. Which modality would be most appropriate to reduce inflammation and promote healing for her lateral epicondylitis? A. Superficial moist heat. B. Paraffin bath. C. Iontophoresis with dexamethasone. D. Transcutaneous electrical nerve stimulation, TENS. Answer: C. Iontophoresis with dexamethasone. This question focuses on selecting the most appropriate modality for a subacute or chronic inflammatory condition like lateral epicondylitis, tennis elbow, especially when initial conservative measures have failed. Iontophoresis with dexamethasone is highly effective because it delivers a localized anti-inflammatory corticosteroid directly to the inflamed tissue using an electrical current, bypassing systemic side effects. Superficial moist heat and paraffin baths are primarily used for pain relief and increasing tissue extensibility, but not directly for reducing inflammation in depth. TENS is a pain management modality, not an anti-inflammatory one. For instance, this targeted delivery can be very beneficial for a localized tendonitis. When inflammation is the primary issue, consider therapies that deliver anti-inflammatory agents directly to the affected area. Question 8. A 72-year-old patient with rheumatoid arthritis presents with significant ulnar drift of the fingers and subluxation of the MCP joints, causing functional impairment. Which splint design would be most appropriate to improve hand function and joint alignment during daytime activities? A. A static volar wrist cock-up splint. B. A dynamic MCP extension splint. C. A soft neoprene thumb spica splint. D. A custom-molded resting hand splint with ulnar deviation strap. Answer: D. A custom-molded resting hand splint with ulnar deviation strap. This question addresses the splinting needs for a patient with rheumatoid arthritis experiencing ulnar drift and MCP subluxation, highlighting the importance of functional alignment. A custom-molded resting hand splint with an ulnar deviation strap is most appropriate for these deformities as it aims to provide support and alignment to the wrist, MCP joints, and fingers, while the ulnar deviation strap specifically helps to counteract the deforming forces of ulnar drift. A volar wrist cock-up splint does not address the MCP joint deformities. A dynamic MCP extension splint is for flexion contractures, and a thumb spica addresses the thumb, not the ulnar drift. For example, this splint would help prevent further ulnar deviation and support the MCP joints, potentially improving pinch and grasp. Always choose a splint that directly addresses the specific deformities and functional limitations present. Question 9. A patient is being evaluated for a suspected scaphoid fracture after a fall on an outstretched hand. Which clinical finding is most suggestive of this injury, even if initial radiographs are negative? A. Tenderness over the distal radioulnar joint, DRUJ. B. Pain with resisted wrist extension. C. Tenderness in the anatomical snuff box. D. Positive Finkelstein's test. Answer: C. Tenderness in the anatomical snuff box. This question tests your ability to identify the hallmark clinical sign of a scaphoid fracture, which is often difficult to detect initially on radiographs. Tenderness in the anatomical snuff box is the most classic and critical clinical finding, highly indicative of a scaphoid fracture, even if initial X-rays appear negative. Scaphoid fractures are prone to delayed union or non-union due to their tenuous blood supply, making early diagnosis crucial. Tenderness over the DRUJ suggests distal radioulnar joint pathology, pain with resisted wrist extension points to extensor tendonitis, and a positive Finkelstein's test indicates to Quervain's tenosynovitis. For instance, palpating the specific area elicits sharp pain if the scaphoid is fractured. Always consider a scaphoid fracture if snuffbox tenderness is present after a FUSH injury, even if initial imaging is unremarkable, and recommend follow-up imaging if symptoms persist. Question 10. A 40-year-old female presents with pain, swelling, and palpable crepitus on the radial side of her wrist, worsened by gripping and thumb movements. Finkelstein's test is positive. She has failed conservative management. She is considering a surgical release. Postoperatively for a de Quervain's release, what is the most important initial management strategy? A. Immediate full active range of motion of the thumb. B. Strict immobilization in a thumb spica splint for 6 weeks. C. Early active range of motion exercises for the thumb and wrist, focusing on tendon gliding. D. Aggressive strengthening exercises for the wrist extensors. Answer: C. Early active range of motion exercises for the thumb and wrist, focusing on tendon gliding. This question focuses on postoperative management following a de Quervain's release, which involves surgically decompressing the first dorsal compartment. The most important initial management strategy is early active range of motion exercises for the thumb and wrist, specifically focusing on gentle tendon gliding. This approach helps prevent adhesions and promotes full excursion of the abductor pollicis longus, APL, and extensor pollicis brevis, EPB, tendons. Immediate full active range of motion might be too aggressive, strict immobilization can lead to stiffness and adhesions, and aggressive strengthening is introduced much later. For example, a therapist might guide the patient through gentle thumb abduction and extension movements. The goal is to facilitate smooth tendon gliding while managing postoperative pain and swelling. Question 11. A patient with a history of cervical radiculopathy presents with new onset of numbness and tingling specifically in the ring and small fingers, and some perceived weakness in grip strength. Which dermatome and peripheral nerve are primarily implicated by these new symptoms? A. C5 dermatome, musculocutaneous nerve. B. C6 dermatome, radial nerve. C. C7 dermatome, median nerve. D. C8/T1 dermatomes, ulnar nerve. Answer: D. C8/T1 dermatomes, ulnar nerve. This question requires linking specific sensory and motor deficits to their corresponding nerve and spinal nerve root distributions. Numbness and tingling in the ring and small fingers, digits 4 and 5, and weakness in grip strength are classic symptoms of ulnar nerve involvement, which receives innervation from the C8 and T1 spinal nerve roots. The C5, C7 dermatomes and other peripheral nerves listed, musculocutaneous, radial, median, innervate different areas of the arm and hand. For instance, a patient with cubital tunnel syndrome would present with exactly these symptoms. It's crucial to differentiate between cervical radiculopathy affecting the C8/T1 nerve roots and a peripheral ulnar nerve compression, example cubital tunnel, as both can present similarly. However, the question asks about the primary dermatome and nerve involved in the new specific symptoms. Question 12. A 32-year-old male presents with right hand pain and swelling, diagnosed with Kienbeck's disease, avascular necrosis of the lunate. He reports significant functional limitations. What is the primary reason for early intervention in Kienbeck's disease? A. To prevent progression to wrist fusion. B. To minimize lunate collapse and prevent secondary degenerative changes. C. To improve revascularization of the lunate spontaneously. D. To address associated carpal tunnel syndrome symptoms. Answer: B. To minimize lunate collapse and prevent secondary degenerative changes. This question focuses on the rationale behind early intervention in Kienbeck's disease, a condition characterized by avascular necrosis of the lunate bone. The primary reason for early intervention, often involving surgical procedures such as radial shortening or capitate lengthening osteotomy, is to unload the lunate, thereby minimizing its progressive collapse and preventing subsequent secondary degenerative changes, arthritis, in the wrist. While preventing fusion is a long-term goal, it's not the primary immediate reason for intervention. Spontaneous revascularization is rare, and carpal tunnel syndrome is a potential complication, not the main concern. For instance, if the lunate collapses, it destabilizes the entire wrist, leading to widespread arthritis. Early diagnosis and intervention are critical to preserve wrist mechanics and prevent irreversible joint damage. Question 13. A 50-year-old patient reports progressive difficulty extending her ring finger, often requiring her to manually straighten it with a pop. She experiences pain over the volar aspect of the MCP joint. Which of the following is the most appropriate initial non-operative intervention? A. Immediate steroid injection into the flexor tendon sheath. B. Nighttime static progressive splinting of the finger in full extension. C. Custom fabricated MCP joint blocking splint. D. Activity modification, gentle massage, and a volar MCP blocking splint to limit full flexion. Answer: D. Activity modification, gentle massage, and a volar MCP blocking splint to limit full flexion. This question describes classic symptoms of trigger finger, tenosynovitis, characterized by painful catching or locking of a digit, often requiring manual extension. The most appropriate initial non-operative intervention involves a combination of activity modification to reduce repetitive gripping, gentle massage to the A1 pulley area, and a volar MCP blocking splint. This splint limits full MCP flexion, and thus full tendon excursion, allowing the inflamed tendon to rest and reduce friction at the A1 pulley without requiring a static progressive splint, which is for increasing range of motion. An immediate steroid injection might be an option, but initial therapy typically includes less invasive measures first. For example, advising the patient to use adaptive grips on tools can reduce stress. The key is to reduce irritation at the A1 pulley and allow the inflamed tendon to heal without triggering. Question 14. A patient is referred for a wrist injury after a fall. You suspect a triangular fibrocartilage complex, TFCC, injury. Which specific maneuver or test would best assess the integrity of the TFCC? A. Watson's scaphoid shift test. B. Fovea sign. C. Grind test of the thumb CMC. D. Phelan's test. Answer B. Fovea sign. This question tests your knowledge of specific special tests for wrist injuries, particularly for the triangular fibrocartilage complex, TFCC. The Fovea sign, which involves applying direct pressure with the examiner's thumb into the soft spot between the ulnar styloid and flexor carpi ulnaris tendon, is highly specific and sensitive for detecting TFCC tears. While Watson's scaphoid shift test assesses scapholinate instability, the grind test evaluates thumb CMC osteoarthritis, and Phelan's test screens for carpal tunnel syndrome. None directly assess the TFCC. For example, pressing into this specific area on the ulnar side of the wrist will elicit sharp pain if a TFCC tear is present. Always target your special tests to the suspected anatomical structure to maximize diagnostic accuracy. Question 15. A 68-year-old patient is 3 months post-total wrist arthroplasty. She presents with persistent moderate wrist extension lag. What is the most appropriate long-term exercise strategy to address this limitation? A. High load, low repetition strengthening exercises for wrist extensors. B. Gentle active range of motion exercises within pain-free limits. C. Passive stretching into full wrist extension by the therapist. D. Use of a static progressive splint to increase wrist extension. Answer D. Use of a static progressive splint to increase wrist extension. This question deals with addressing a persistent range of motion deficit, specifically an extension lag, following total wrist arthroplasty. When gentle active range of motion, AROM, and initial strengthening haven't resolved the lag, a static progressive splint is the most appropriate strategy. This splint applies a low load, prolonged stretch to the joint, gradually increasing the range of motion over time by remolding soft tissues and overcoming capsular tightness. High-load strengthening might not improve range and could stress the implant. Gentle AROM alone is insufficient for a persistent lag, and aggressive passive stretching could be detrimental to the healing joint. For instance, the splint would be adjusted daily to apply gentle, continuous pressure into greater extension. The goal is to restore functional range of motion through controlled, sustained stress on the stiff tissues. Question 16. A patient presents with a laceration over the dorsum of the hand, resulting in a zone 3 extensor tendon injury of the index finger. After primary repair, which of the following splinting positions is most appropriate for initial immobilization? A. Wrist in 30 degrees of flexion, MCP joints in 0 degrees, IP joints in 0 degrees. B. Wrist in 45 degrees of extension, MCP joints in 0 to 10 degrees of flexion, IP joints in 0 degrees. C. Wrist in 0 degrees, MCP joints in 70 degrees of flexion, IP joints in 0 degrees. D. Wrist in 30 degrees of flexion, MCP joints in 70 degrees of flexion, IP joints in 0 degrees. Answer B. Wrist in 45 degrees of extension, MCP joints in 0 to 10 degrees of flexion, IP joints in 0 degrees. This question tests your knowledge of appropriate splinting positions for extensor tendon repairs, specifically for zone 3, which is over the metacarpophalangeal, MCP, joint. For zone 3 extensor tendon repairs, the ideal initial splinting position is typically with the wrist in 45 degrees of extension, the MCP joints in 0 to 10 degrees of flexion, and the IP joints in 0 degrees, full extension. This position provides slack to the extensor tendon at the repair site, protecting it from undue stress, while maintaining a slight MCP flexion to prevent collateral ligament shortening. Other options either put excessive tension on the repair or lead to joint stiffness. For example, a short arc motion splint would be configured this way. Proper splinting position is paramount to protect the repair and prevent postoperative complications like extensor lag. Question 17. A patient with a chronic full-thickness supraspinatus tendon tear undergoes rotator cuff repair. Postoperatively, which of the following is an absolute contraindication for the first 6 weeks? A. Passive shoulder range of motion. B. Gentle pendulum exercises. C. Active internal and external rotation exercises. D. Active elevation above 90 degrees. Answer: D. Active elevation above 90 degrees. This question assesses your understanding of absolute contraindications in early postoperative rotator cuff repair protocols, which are critical for preventing re-rupture. During the initial 6 weeks after a rotator cuff repair, active elevation above 90 degrees, or any active range of motion, is an absolute contraindication because it places significant stress and contraction force on the repaired tendon, risking re-rupture. Passive shoulder range of motion and gentle pendulum exercises are often encouraged to prevent stiffness without active muscle contraction. Active internal and external rotation are also typically avoided actively in this early phase, but active elevation is the most prominent contraindication. For example, asking the patient to lift their arm to brush their hair is too much activity for the early phase. Protection of the repair site is paramount in the initial healing phase to ensure successful tendon integration. Question 18. A 58-year-old construction worker sustained a crush injury to his right hand, resulting in significant edema, pain, and limited range of motion, despite wound healing. His skin appears shiny and warm, and he guards the hand. He reports extreme pain with light touch. Which condition is most likely developing, and what is a critical early intervention strategy? A. Severe cellulitis, immediate antibiotics. B. Complex regional pain syndrome, CRPS, type 1, pain management and active, non-provocative motion. C. Acute osteomyelitis, urgent surgical debridement. D. Dupuytren's contracture, collagenase injection. Answer: B. Complex regional pain syndrome, CRPS, type 1, pain management and active, non-provocative motion. This question describes classic signs and symptoms of complex regional pain syndrome, CRPS, type 1, which typically presents after an injury with disproportionate pain, vasomotor changes, shiny skin, temperature changes, swelling, and allodynia, extreme pain to light touch. A critical early intervention for CRPS is aggressive pain management combined with active, non-provocative motion and desensitization techniques. Cellulitis would present with more acute infection signs, osteomyelitis is a bone infection, and Dupuytren's contracture is a fibrotic condition causing finger flexion. For instance, encouraging the patient to perform gentle mirror therapy or light touch desensitization can be very effective. Early recognition and initiation of appropriate pain management, desensitization, and active movement are vital to prevent the progression and chronicity of CRPS. Question 19. A 25-year-old patient presents with a dorsal wrist ganglion cyst causing pain and limited wrist extension. She desires non-operative management. What is the most appropriate initial treatment approach? A. Surgical excision. B. Aspiration and steroid injection. C. Rest, activity modification, and wrist immobilization in slight extension. D. Aggressive wrist strengthening exercises. Answer: C. Rest, activity modification, and wrist immobilization in slight extension. This question focuses on the initial non-operative management of a dorsal wrist ganglion cyst, a common benign soft tissue mass. The most appropriate initial treatment involves rest, activity modification to reduce irritation, and wrist immobilization, often in slight extension. This aims to reduce the fluid accumulation within the cyst and decrease symptoms. While aspiration and steroid injection are options, they are not always the initial approach and have high recurrence rates. Surgical excision is typically reserved for persistent, symptomatic cysts that fail conservative management, and aggressive strengthening could exacerbate symptoms. For example, a soft wrist brace could be used during activities. Many ganglion cysts can resolve spontaneously or with conservative measures, so limiting aggravating activities is key. Question 20. A patient presents with a chronic boutonniere deformity of the small finger, characterized by PIP flexion and dip hyperextension. What is the primary focus of long-term splinting for this condition? A. To maintain the PIP joint in full extension. B. To allow full active PIP flexion and dip extension. C. To block dip hyperextension while allowing PIP extension. D. To mobilize the PIP joint into flexion using dynamic traction. Answer: A. To maintain the PIP joint in full extension. This question addresses the splinting principles for a boutonniere deformity, which results from disruption of the central slip of the extensor mechanism at the PIP joint. The primary focus of long-term splinting for a boutonniere deformity is to maintain the PIP joint in full extension, or near full extension, while allowing free active range of motion of the dip joint. This position facilitates the healing of the central slip and prevents further PIP flexion contracture, which is the hallmark of the deformity. Blocking DIP hyperextension is not the primary goal, nor is allowing full PIP flexion, which would worsen the deformity, or dynamically flexing the PIP joint. For example, a custom-molded PIP extension splint, example of boutonniere splint, would be used. The goal is to passively extend the PIP joint while allowing active dip motion, thus restoring the balance of the extensor mechanism. Question 21. A patient with a complete laceration of the median nerve at the mid-forearm undergoes primary repair. Postoperatively, what is the most critical immediate concern regarding nerve recovery? A. Prevention of neuroma formation. B. Prevention of intrinsic muscle atrophy. C. Prevention of joint stiffness and edema. D. Protecting the repair site and promoting nerve regeneration. Answer: D. Protecting the repair site and promoting nerve regeneration. This question focuses on the immediate postoperative priorities following a complete median nerve laceration and repair. The most critical immediate concern is protecting the repair site from undue stress that could lead to rupture and creating an optimal environment for nerve regeneration. While prevention of neuroma formation, intrinsic muscle atrophy, and joint stiffness are all long-term considerations, they are secondary to the primary need to ensure the integrity of the nerve repair itself. For example, immobilizing the wrist in a position that provides slack to the nerve, typically wrist flexion, is done to protect the repair. The success of nerve regeneration hinges entirely on maintaining the structural integrity of the surgical repair. Question 22. A patient with a chronic traumatic wrist instability is referred for evaluation. You perform a Watson's scaphoid shift test, and it elicits a clunk and pain with pressure on the scaphoid tubercle. What does a positive Watson's test primarily indicate? A. Lunotriquetral ligament instability. B. Scapholunate ligament instability. C. Triangular fibrocartilage complex, TFCC, tear. D. Distal radioulnar joint, DRUJ, instability. Answer: B. Scapholunate ligament instability. This question tests your knowledge of specific special tests for wrist instability. A positive Watson's scaphoid shift test, characterized by a palpable clunk or pain with pressure on the scaphoid tubercle while the wrist is moved from ulnar to radial deviation, is the primary clinical indicator of scapholunate ligament instability. This test specifically evaluates the integrity of the scapholunate ligament, which is crucial for maintaining carpal bone alignment. Other tests are used to assess lunotriquetral instability, TFCC tears, or DRUJ instability. For instance, if the scaphoid subluxes dorsally and then clunks back into place, it suggests instability between the scaphoid and lunate. Always remember that each special test targets a specific ligament or joint complex, guiding your differential diagnosis. Question 23. A 62-year-old patient with a long history of osteoarthritis and a significant malunion of a distal radius fracture has developed a painful, stiff wrist with limited range of motion. She is unable to perform many daily activities. What is the most appropriate long-term intervention to restore function and reduce pain? A. Aggressive joint mobilization and strengthening exercises. B. Corticosteroid injections and activity modification. C. Total wrist arthrodesis, fusion. D. Dynamic splinting for range of motion. Answer: C. Total wrist arthrodesis, fusion. This question presents a challenging scenario of a painful, stiff wrist with limited function due to severe osteoarthritis and malunion, indicating significant degenerative changes. In such advanced cases where conservative management and less invasive surgical options have failed, total wrist arthrodesis, fusion, is often the most appropriate long-term intervention. While it sacrifices wrist motion, it reliably provides pain relief, stability, and allows for improved grip strength, significantly enhancing overall function in the presence of severe arthritis and malunion. Aggressive mobilization might worsen symptoms, injections offer temporary relief, and dynamic splinting is unlikely to overcome significant structural deformity and pain in this severe stage. For example, fusing the wrist might allow a patient to finally push up from a chair without severe pain. When pain and instability are chronic and severe, fusion often provides the most predictable and lasting relief and functional gain. Question 24. A patient is referred for scar management following a deep burn to the palmar aspect of the hand, which has healed with hypertrophic scarring causing a flexion contracture of the MCP joints. Which intervention is most appropriate for this type of scar? A. Silicone gel sheeting and sustained pressure. B. Gentle massage with lubricating lotion. C. Cold packs to reduce inflammation. D. Aggressive passive stretching. Answer: A. Silicone gel sheeting and sustained pressure. This question addresses the management of hypertrophic scars and resulting contractures, a common and challenging problem in hand therapy, particularly after burns. For hypertrophic scarring leading to contractures, silicone gel sheeting combined with sustained pressure, example through pressure garments or custom splints, is the most appropriate intervention. Silicone helps to hydrate the scar and reorganize collagen, while sustained pressure reduces blood flow and collagen synthesis, preventing excessive scar tissue formation and promoting flattening and softening. Gentle massage is helpful but not sufficient alone. Cold packs don't address hypertrophic scarring, and aggressive passive stretching could irritate the scar and worsen the contracture. For example, wearing a custom-molded anti-contracture splint with silicone lining applies constant pressure and can dramatically improve scar appearance and function. The goal is to remodel the scar tissue and prevent further contracture, restoring range of motion. Question 25. A patient presents with persistent symptoms consistent with carpal tunnel syndrome, including nocturnal paresthesias in the median nerve distribution and positive Tinel sign at the wrist. Nerve conduction studies confirm severe median nerve compression. What is the most important education point for this patient regarding postoperative recovery after carpal tunnel release? A. Expect immediate and complete resolution of all symptoms after surgery. B. The importance of nerve gliding exercises to prevent adherence of the nerve. C. Aggressive strengthening of the hand and wrist muscles will be necessary immediately. D. Avoiding all hand use for at least 6 weeks post-surgery. Answer B. The importance of nerve gliding exercises to prevent adherence of the nerve. This question focuses on critical patient education following a carpal tunnel release, particularly when nerve compression is severe. The most important education point regarding postoperative recovery is the importance of performing nerve gliding exercises. These gentle exercises help to mobilize the median nerve within the carpal tunnel, preventing adhesions and promoting smooth gliding, which is crucial for symptom resolution and optimal nerve recovery. Patients should not expect immediate and complete resolution, especially with severe compression, and aggressive strengthening is introduced later, while avoiding all hand use for 6 weeks is an overrestriction that would lead to stiffness. For example, teaching the patient a series of gentle wrist and finger movements that encourage nerve excursion is key. Emphasize that active participation in these specific exercises is vital for long-term symptom relief and functional recovery.